Welcome everybody. So I hope you can all see this screen. We'll have a setup today. We'll walk you through it briefly just before, or not before we have properly introduced ourselves and asked you a question. So today you are at this session, Horizon 2037 Guiding Principles for the Future Care. So make sure you have your writing materials ready. I want to give the word to Marius Buiting to introduce himself, and then I will introduce myself and we ask you a question, and then we'll start this session with the agenda and the content. Marius.
Hi, I'm Marius Buiting. I'm currently the director of a society in the Netherlands that is collecting all the non-executive board members of whole healthcare and welfare organizations in the Netherlands. So we have an overview of the, you could say, whole healthcare situation in the Netherlands. I'm also the chairman of the special interest group of EHMA on health futures. And I also, in my present position, am an advisor of the Dutch government on what's coming up for the next decade in terms of restructuring healthcare. So that will be, I think, the heads that I have on during this presentation.
So thank you so much. My name is Matthijs Zwier. I'm a Quartermaker for the Dutch Society of Non-Executive Board Members, the society of which Marius is the president. Besides that, I do lots of work in and around healthcare on city level, but also on practice level. Besides that, I'm on the advisory board of the European Health Futures Forum. Today we will hope to give you 7 guiding principles for future care, but not just before we want to ask you a question. This will be the agenda today. So the first part is done. The second part, introduction of participants. We want you all to at least write your name in your screen, but also in the comment box from which background you are and from which country. So which professor, if you are a researcher, a health manager, an advisor, and from which country you come today. Then we will go into the 7 guiding principles for future care with the presentation or the story that Marius will hold. We have a question and answers after it. Then the second part is learning in times of COVID. And then again, the question and answers and the closing comments. You all have the possibility to meet in a digital lobby afterwards from 12 to 12:15. We really would like you to type the information in the chat box. So who are you as a background and where do you come from?
Let's do that for 2 minutes. And
yeah, the 2 minutes.
We can also read it here.
And then we can read along. And that's just prevent of running out of time. So welcome, Nabil. The Netherlands is well represented in this group, I see. Great. Astrid, welcome. So as you continue, please all type your background so we can save the chat so we know who you are and where you come from. I think we can now slowly start into the 7 guiding principles. Marius will enter the screen a little bit more. We start with an overall picture.
Yeah.
Marius, the floor is yours.
Let's get it started. We will give a presentation, and I think Emma will help you also to get this presentation later, so you don't have to write with it, but just be in the presentation. I think that's the best. First, what we will show you is an overall picture of, you could say, the developments of healthcare, how we see it And I think this already started in, you could say, around 2000. So it's a long-standing development. You could say it's a transition or transformation of present or current healthcare systems into, you could say, future healthcare systems. And I think many of the countries are in the middle of this kind of transitions. Some are maybe a little bit more ahead, or maybe a little more backwards, but I think it's good to see this overall picture. Let's go to the upper left top corner, and you could say we have a beautiful healthcare in many countries, but this healthcare also made people dependent on, you could say, the healthcare systems. It was paid for doctors and nurses as professions to care of us. We didn't have to think so much about our own health anymore. And when you look to the right you could say, arrow, then in the end, we want to go to a more, you could say, fully empowered healthcare system where people are participative. We also have this whole idea of Martin Huber, WHO, who inspires us to go to the whole idea of positive health. I come to that later. And what this means is also that we will see a dimension from, you could say, the dependence on the healthcare and issues that are standardized by professions or healthcare institutes to a more personalized health. And we see that we have this dimension of that not only the power is in the hands of the professionals or the healthcare institutes, but that we have a self-management and an empowerment of patients. When you look at in the picture of, you could say, dependency, then you could say it's also in the words. We had this whole emphasis of being a patient, and patient means something like waiting for, you are in a passive mode, you could say. And when you look to the whole idea is that we had this idea of not having any disease anymore. When you have a disease, this was this whole idea of how can we get rid of that disease. So it was not about an emphasis on good life or an emphasis on citizenship. It was being a patient, having a disease, and that was the overall picture. What we see in the future or next decades, and what I say it's an ongoing movement, is that we see that we want to have more mobility, a flexible healthcare, more locally organized, and that new, you could say, powers come in place. There it is, and that is what we say. It's an other way how people are engaging in healthcare, and this also means that the current healthcare systems and professions have to make, you could say, a great move from the all-knowers and know who's best, what's best for people, to, you could say, more guiding people, coaches, co-creators, all this kind of things, and that's not an easy thing. When you look, for example, in the medical education or the nursing education, overall still the education is about we know better or we know best. And I think this is really a transformation that will take several more decades, but I'm very confident that it will happen. So what about those 7 guiding principles? When you look to you could say a theory of transformation, then the whole idea is that if we have guiding principles, so you could see more deeper movements of change, that could really make this long-term transformation. When you look to innovation, especially what we call the sociological innovation, so not so much the technological innovation or the innovation of practice, that means that you have to have an, you could say, in-depth movement of the way how people behave to each other. And I think the most important of this transformation is that the whole equilibrium between, you could say, the professionals and the people who are dependent on professionals will change in a way that will be more, you could say, a balance between the two. And that's all, you could say, dependent of possibilities, also of technology. But the whole idea is that the principles are more guiding than, you could say, the current status of healthcare system or the payment system, etc. Now, these guiding principles, what we will present are, it's partly a Dutch story, but it's also a European story, a worldwide story. It's based on three, you could say, ideas. The first, and I really recommend to read this book if you didn't do it, is based on a theory of Otto Scharmer. And Otto Scharmer, who's really standing on the shoulders of people like Senge or Duran, people who were really involved in quality, he is saying, in a way, say the future, we are learning already in the present. So he called that presence, and the whole idea is, and we'll come back to that on the second part of our presentation, that we learn, for example, a lot in these times of COVID, positive things, maybe also things that are adverse to certain developments. But the whole idea of what he presents in his theory U is that we are going to a complete new way of organizing our societies, and he calls that ecosystems. And a very important term that he uses is the whole idea of emergence. Also, we'll come back to that later. The second, you could say, way how I prepared this whole presentation for you is that we are in a reform of the Dutch healthcare strategy for the next decade. The quite interesting thing is that we at the present stage in the Dutch ministry are not thinking about, oh, we should restructure the system again. No, there is a system, but could we within the system, by guiding principles, transform, you could say, the way how we deliver healthcare step by step. And that is done by a big program in the Dutch society now. And I'm heading this science, you could say, program of that by Zonneweg. Zonneweg is a big funding organization for innovative projects. And it's called de juiste zorg op de juiste plek, what means something, how can we make adequate care on adequate places or in adequate time to improve healthcare. And there's a lot to be done in that field. And the third thing is that we, with a group of people, have formed a couple of years the European Health Futures Forum. I was many years the chairman of the advisory board of the European Health Futures Forum. And when we look to also many other European countries, we see the same kind of developments in Europe. Now we start with those 7 principles. The first one, also referring to Scharmer, he used this word also, co-creation, is the whole idea that there will not be in the future the idea that there is one who knows best, the professional and the person who doesn't know anything, but we will have more, you could say, equilibrium between the knowing of the patient or the citizen and the knowing of the professional, the person who works with groups of patients. And interesting thing is, I think that one of the most driving force of the future healthcare is patient literacy. If we give more information to patients, but not only information like the traditional way of giving information, but really make patients literate so that they really know best about their own healthcare. And of course, there will be a difference between people who are well educated and maybe less educated, people who are living in more social deprived areas or in more, you could say, better or well-doing, you could say, regions. But I think we can still make a huge movement in that direction. The second thing I will really plead for, and that is the whole idea of expert patients. What's an expert patient, in my opinion? I think everybody that is in the bed of a hospital or that visits a GP is an expert patient on his own or her own behalf. And I think when doctors, nurses, paramedics are more learned to really ask feedback from their patients in what is working with me, what is something what I could give you as an advice as a professional, that the learning would be much more faster, and that should start already in medical education. What we see in Dutch healthcare nowadays, that especially in the field of mental health, we have very interesting examples of this, that there is even academies, so schools of people who have a certain, you could say, mental disorder, and they learn not only their own fellow people with the same disorder, but also, for example, GPs or nurses, about how it is to have this disorder. And by giving this kind of lessons, this we call this how to come back in society academies. It's about how can I live with my disorder, my mental disorder, and I, as a patient, can learn that to the professionals. And the third thing, what we see, and I think this is a huge movement in the Netherlands, but we see it more and more also in other countries, is community empowerment. What we see in the Netherlands is that we have now over 400, you could say, community corporations that are involved in healthcare. And they try to do as much as possible what the community can do in terms of healthcare. And a beautiful example of this is in a small village not far from Utrecht. It's called Austerlitz, where they have now even the ownership of life sustainable houses, that they can take care of people in their community that should maybe in a couple of decades or maybe a decade ago, or in many other communities, go to nursing homes or to hospitals, and they take care of that as a community. So that's very interesting movement, community empowerment. We go to the second guiding principle. This is what this committee where I'm in at Zonneweg is about. It's about what is the coherent scale of things. And this is in different countries, I think, better organized than in other countries. But what we see in these times of COVID, that in none of the European countries, it's really perfect. So sometimes we see on a European scale a lack of, you could say, means, and we are now with the European Union trying really to, for example, when it goes from vaccines or protecting materials or test material, not to only organize it well in our own country, but also to get a sort of solidarity within Europe and help each other in this, for example, very difficult circumstances of the COVID. But also on the country level, we have to find a coherent scale. A beautiful example in the Netherlands was that we have children with cancer. And at a certain moment, the patient organization, that is the parents of the children with cancer, said, we have about 8 academic hospital centers in the Netherlands, and they were fighting, you could say, who could be the group that is best to take care of those patients. But the series of patients are very small. So they didn't learn by those very small series. They were more competing about the patients than working together. And then there was this movement to create one central cancer center that's called the Queen Maxima Center for patients with children with cancer. And they have now a centralized research and treatment center in the middle of our country. They work together with all the other academic and regular hospital centers and with GPs. And I think this is a beautiful example how you can coordinate things on a right scale on the country level. But also, what about regional levels? That is not a very strong point, for example, in the Netherlands. Maybe it's much better organized in England with trusts, or in Scandinavian countries, or in Germany, where it much more is on, you could say, the level of not of the federation, but of the states. So what should be coordinated in a regional level? And for example, in the Netherlands, we have a very, you could say, national system and with national organizations, but the working together in the regions can much be improved. And very important, I told you about this local level, and local level, I mean really local level. That could be really on the level of a village or a neighborhood. And how can you empower the neighborhood and the village, and how to in a way work with that possibilities of that neighborhood and that village, and then build from that to, you could say, a more regional and in the end a national healthcare system. So it really is a movement to start within the empowerment of the citizen and then building up to other levels. Now we go to the third. I think there is an overall development of, you could say, the development of people who grow older. That's, I think, a very positive thing. But growing older in a modern society is not also always an easy situation. When we look to the chronic conditions, so you could say the power of modern healthcare is that we can deal with a lot of chronic diseases and conditions like COPD, or with things like heart failure or heart diseases, rheumatic diseases, etc. But what we see, how more successful we are, how more there will be a piling up of chronic diseases when you grow older. And you see in a way that the Dutch healthcare system, but I think in many healthcare systems, we can't at the end have the labor force, the equipment, the facilities to give all those people, you could say, a nice living environment till the end of their life. And there's another development, and that is that people don't want to go to hospitals anymore or to nursing homes. They want, with modern technology, with support in their own environment, to stay at home. But what to do? Our healthcare systems are very institutionalized, and we really have to have a more proactive attitude. That is, I think, one of the guiding principles. We know that frailty will be part of our life, and how can we make, for example, a more sustainable housing, more sustainable environment? Many cities nowadays are not able anymore to support really communities and people who are in frailty. And I think we really have to think about what is a modern city will look like, what is a modern village look like, what is a house look like in future, and how can we make this more sustainable. Yeah, I already introduced a little bit the problem of the labor force. When we look to the Dutch healthcare system, and again, I see it in many European countries nowadays, is that the biggest problem is not the costs of healthcare, but it's the lack of labor. And that gives also a tension in Dutch healthcare, what I see when I'm running those non-executive boards, and that is that we have more and more people leaving our healthcare workforce, but they don't leave the healthcare workforce in a total. No, they go in new networks, professional networks, standalone, and then we have to, you could say, enter them in our hospitals, and then we, or nursing facilities, or facilities for handicapped people, and then they cost a lot more because we have to hire them, and it is a very difficult mechanism now in our quite open market system in Dutch healthcare. So what we see is that the amount of money that we have to hire people in our facilities is going really skyrocketing, and that is really disrupting, or you could say disorganizing our present healthcare system. So we have to find out how we can do more with less, you could say, workforce. And that is, I think, the overall movement that we have to make, and not to start to compete on workforce and then make it impossible to run healthcare, you could say, more in a balanced way for everybody. And I think there is a couple of beautiful new trends, but we have, I think, to implement them much further than we do now. I think you are quite well informed about things like value-based healthcare, lean management, but I want to emphasize two other things. And one is the redesigns. I think that we see in many countries now that we have a lot of, you could say, chains. We organize things in step-by-step approaches. But I think that we should organize things much more in what we call platforms. I give a small example about myself. So about 2 years ago, I had a small, you could say, disturbance of my vessels in my head, and I had some infarcts of my brain. But okay, after a short while, it worked fine again. But then I had to go to the cardiologist, to the neurologist. There was a nurse practitioner. There was even, you could say, a supportive nurse that called me at home. There was the rehabilitation doctor, the labor doctor, the general practitioner. And all the people, in a way, did this more or less the same thing. So there was a lot of redundancy, you could say, of things, and all doing the same thing, the same tests, etc. So I think we should find more powerful redesigns where the patient, for example, with a nurse practitioner, can be really in, you could say, have the stage management of our own care, and that we, in a way, can click on the things that we really need and not all this redundant healthcare. And I think trust will be a very important thing. I'm from the world of quality and quality assurance and quality improvement. And already in, you could say, the last decade of the last century, I was very, very worried about the whole things, what went on accreditation, accountability, all these kind of things. And what we see now in the Netherlands is that professionals are about 15 to 20% of their time involved in all kind of accountability registrations, certification of their wards, all these kind of things, and that costs an awful lot of time, and that is also really, you could say, disencouraging the professionals in the present healthcare system. But then we have to make a new way of movement, that how can we trust our professionals and really be supportive to them instead of constantly ask them for being accountable. The fifth guiding principle is, I think, an overall principle that is not only helping healthcare, but also other parts of society. And I just invite you to go, for example, to the UN Sustainable Development Goals. That's an overall framework about that all things come together. It's about, it's not only that we have to take care of, you could say, healthcare, but also about our environment, that there should be an equilibrium or a balance between the rich and the poor, not only worldwide, but also in our own countries. A rich country as the Netherlands has an awful lot of people that have personal debts. It's also to balance with, you could say, our environment, with our energy, all this kind of things. So I think that's a very interesting development, to look to those sustainable development goals and also make them, you could say, practical for healthcare systems. Maybe a complete other way of thinking is the whole idea of informal caregivers or volunteers in balance with professionals. What we see in many of our care, for example, facilities for elderly people or for handicapped people, is that we have not enough professionals to do all the work that is needed to give people also, you could say, a nice life. But on the other hand, we have a lot of people, and I think it is really, we should have a better understanding of that, is that we grow older. And the WHO a couple of years ago did some measurement about how many times a certain generation gives to another generation in terms of volunteer work, informal care, etc. And the interesting thing is, when you look then, for example, from an age between 20 and 30, you give to others, let's say, half an hour a day, and that's especially for your children, you could say. When you are a little bit older, between 30 and 40, that grows to 1.5 hour a day, etc. And what is quite interesting, when you look, for example, to the healthy, more healthy generation that is between 60 and 80, they give about 6 hours a day in, you could say, informal care, volunteership, care for their grandchildren, etc. And that's amazing. They are, you could say, an unbelievable big task force. And I think we should really see this in our modern society, that we have a lot of possibility also, because we are more healthy when we are on a certain age, much more healthy than my grandparents were. And that is also a huge, you could say, force for a modern, more balanced healthcare. But then we also have to find new ways how to work together. And what we see, for example, in the Netherlands, that professionals and, you could say, informal caregivers are hardly linked to each other. There should be a lot more, you could say, knowledge and support from professions to informal caregivers to make this more balanced ecosystem. And integrated arrangements, what I mean by that is not just adding up all kinds of things, but really try to make it more coherent together. A very interesting example is, for example, in the Netherlands, the development of palliative care networks. And that is not working in chains, but really working together in an integrated way. We are almost there. Yeah, I think in the overall picture, I already mentioned the whole idea of personalized health or personalized medicine. And we see big developments now. The one country maybe moves faster than the other country. But for example, in oncology, there is this huge development the last years in not giving overall, you could say, schemes of the radiotherapy or all kinds of pharmacotherapy, but do it much more organized and focused on the specific elements of this person and this cancer. And you see huge developments, for example, in immunotherapy, in more focused, you could say, radiotherapy. And I think this development will go on and makes the burden of healthcare much lower and the results much bigger. And nursing homes. In the Netherlands, we have a new scheme, and we have the same scheme in the, you could say, institutes or the homes for mentally handicapped people, is that we say, no, we should not have a standardized way of taking care of people. No, we should really go in the lives, the history of, the personal history of people. And we have to have a way of taking care of people as they are, in what is their personal history, what works best for them. And that's really a big move that we are trying to make. And what we see, for example, in the Netherlands, that there is a big movement in this, but that there is a lot of work to do. And that we see now a couple of institutes that are far ahead of others, but how to move the whole healthcare system in that direction. Pharmacotherapy, also I already mentioned, there could be much more, you could say, focused healthcare, especially for the elderly. I'm amazed that still people who are above 80 have the same kind of pharmacotherapy than people that are much younger. While their systems are not working that fast anymore, their liver and their kidneys, etc. And it's amazing that we still give a lot of medicine that is only working for secondary prevention for people who are elderly, who should not do that anymore. How can we be more focused and more personalized? And also lifestyle interventions. And many doctors give lifestyle interventions, but hardly think about in what circumstances do those people live. Is this really a lifestyle intervention that they can manage in their own situation? Yeah, and then to conclude, very interesting that a Dutch professor, Matthijs, Zwier, in a certain moment said, yeah, we also have to think about a new definition of health and healthcare, and not thinking about, okay, we can abandon diseases. No, we have to live with our diseases and chronic conditions. And the only way how we can do that is when we look to what she called positive health. And positive health is a balance of all the, you could say, life areas where you are in. It's not only about your body, it's also about your spirit. It's also about can you participate in society? What about loneliness? This kind of thing. Also the whole idea of, we had this concept of prevention, but should it not be precaution? That is, you could say, even stronger idea. That is, when you are maybe still doing quite well, can we give you information and ideas that you really feel better, and that you can really organize things in a way that a lot of problems that you could get, that will not happen. I'll give a very small example. For example, when you have a hip replacement, what is precautional care is that you already try to exercise all kind of exercises that you will do after the hip replacement, and that you do these exercises already before, or that you are more fit when you go to an operation theater by already have a good nutrition or doing some gymnastics, etc. Dus the whole idea of precautional care is, it goes a step further than you would say the traditional prevention. Also, I think we should really have more trust in the ability of every individual, because there's still this idea of, we have people who don't know, they are not motivated, etc. No, it's to find the way how we can motivate this kind of people. It's not to say, okay, they are in the box of deprived social circumstances. So no, find the way how we can help them, and there is always something what is in themselves to have a, you could say, a connection with. And invite to contribute. It's quite interesting in the city where we live, and Matthijs maybe later can say a few words about that, is there is a new healthcare strategy in the city of Utrecht that is inviting everybody in the city. So not only people who are in the healthcare systems, but all in the educational systems, or retailers, or people who are running businesses, to think about how they can contribute to make Utrecht a more healthy city. I think this is a lot of talking of my side. I think I give the word back to Matthijs and Luc if there is some recognition of those 7 principles and some questions and answers.
So as you can see, I stopped sharing my screen, so I would please invite you to join us, turn your camera on if possible. Really, I'd like to ask you if you have questions or things you need to clarify about, or examples yourself. We have about 10 to 15 minutes to interact with each other regarding those 7 principles, which I only can imagine raises a few questions. So please, if you have questions, raise your hand and I will give you the floor. Are there any questions? Or yes, Ellie, please unmute yourself. And nice to see you, by the way.
Nice to see you too. And thank you very much for the very interesting presentation. And it's also very comprehensive, those 7 guiding principles for future care. Really interesting. And it makes me think of actually just one question. And it was the 4th principle that triggered me. The principle of less is more. And there you mentioned the value-based healthcare, lean, redesigns, trust of professionals, and things like that. And then there was just one question, actually. I was thinking, will this be enough to transform the system and to tackle actually the biggest problem you mentioned, the lack of labor, which I agree upon. This is a huge challenge we all face in every country. The growing and increasing demand of healthcare because of rising chronic diseases, etc., but not having enough people to tackle this. But I was questioning, actually, will those redesigns, value-based healthcare, lean, etc., be enough?
Yeah, I'm not sure, but I think what I sometimes say is it should be a national sport to make people independent from healthcare. And making people independent is not that you don't care for them anymore, but that you give them means that they can, in a way, care for themselves, or that the community can take care. So it's more a whole idea of how can we, in a way, are in a constantly idea of new interventions, new ways, how we can make people independent. And when you look to other industries, for example, that is the way how we made a huge intervention in terms of the need of workforce. Think about supermarkets, or think about internet, or Wikipedia, etc. It is the whole idea that you make redesigns that make people more independent from, you could say, the labor. And I think that should be a national sport everywhere.
Yeah, I can comment on as well a little bit, Ellie, because so less is more, the fourth principle, is of course also supported by some of the other principles. So a more active community, like Marius said, the Utrecht example. I'm a strategic partner for the City Council of Utrecht, and that's based on multiple factors, but two are quite important, and that's Utrecht is one of the few cities in Europe that has health in all policy. And that means that every policy that will come from Utrecht, health is part of it, and health questions about health and the health of the citizens or inhabitants of Utrecht are raised. And the second one is everybody contributes. So if you have a workforce that's almost depleted or exhausted or on the brink of tipping over, then inviting every single citizen to contribute to health in a way that matches your expertise, experience, needs, etc. And that means for some really, really small, I make 2 extra portions of soup for my neighbor, versus whole corporations in local neighborhoods where people take care of people with low means of nutrition for themselves and cook for 200 or 300 people. And there's a broad range of what people are able and willing, by the way, to do for their neighbors, for their surroundings. Is that an answer, Ellie?
Yeah. Thank you very much. I'm just realizing that maybe what I missed is the digitalization part of it, but I also realized that is more a means than an end. So that's it's an answer. Those are quite interesting principles which can be supported by technological, social innovation, things like that. Yeah.
Thanks so much. I want to give the floor to Nabil, who asked or raised 2 questions in the chat, and afterwards Mariah Jeftic also raised a question. So Nabil, could you unmute yourself and introduce your question?
Well, firstly,
or you said it in the chat, but yeah.
Thank you. Well, so good to see you both after, I think, about a year now, isn't it? Almost. Yeah, thank you. I wish we could be doing this in person. So thank you so much for sharing the insight, I think, firstly. I think the 7 principles are very much what I heard, quite intriguing in lots of ways. It gets you in thinking mode to think about what could you do with them. So I put my questions more specific in the chat. Less is more. When we were talking about that as a principle, you're talking about the skills and the skill mix and the workforce. In the UK, we are seeing quite a lot of traction around diversity and bringing diverse leadership to the boards and to the organization at different levels. And also in that, there's a work around the future generation. We rely quite heavily on volunteers in the UK, as you know. I'm sure it's the case in the Europe as well. But that's depleting in a way that there's no new blood coming into doing more volunteering as it was for the previous generations from us. What are you seeing across Europe? Any insights, any examples you want to share?
Yeah, I think this is also linked with the whole idea of personalization. What we see that in the Netherlands now slowly on, you see this movement that we try to look more at diversity in two ways. Diversity, you can constantly problemize it, but you can also see it as a chance. For example, in the whole idea of our non-executive boards, we try now to see in the city of Utrecht, there is hundreds of different cultures, and how can we find the wisdom in those cultures? So I think when you look especially also to young people, they want to contribute, but then you also have to give them responsibilities and that kind of thing. So I think that is things that you really have to learn, and I see some examples that are very positive, but I think there should be a lot more. And maybe the last thing about to invite young people, when you look, for example, to technical universities, it's quite interesting that, for example, we have this project in the Netherlands, a solar challenge. So we give young people who are on the technical university the challenge to really contribute to future, you could say, automotive. But when you look, for example, to healthcare, we first educate people till they are consultant level 35, and then we give them the responsibility to develop new technology. I think we should give young people, also people who are still in education, the wicked problems, and let them think about it, and maybe they come to solutions where we elderly never thought of.
I can't agree more with that. And we are already seeing some examples of research work going where a parallel board of very young individuals was set up to the main board. Yeah. They all come to the same conclusion towards the end of it pretty much. But the process that the younger board went through is quite interesting to observe, actually.
Yeah.
My second question, if I may, yes. Is around integrated reporting, and of course, the whole situation around the sustainability and all that is fantastic. My question is in relation to kind of the overall topic and theme that is going around in any healthcare setting is around integration and partnership. Oh. Thinking of the models of care which are changing, of course, and are being designed as we sit in here today. What is your view on the accountability and accreditation versus integrated reporting and developing that as a skill and capacity within the system? So by default, you are in the nature of not using just data into information, but using that information as intelligence supported by narrative around who is it for?
Yeah, I hope that maybe other people can contribute to that, because I think the Netherlands is not really the example country in the world for this. I'll give you one example, a story, and then you understand me better, I think, is that at a certain moment, we as non-executive board members were asked by the Dutch Ministry of Health, what about the ways that healthcare facilities have to be accountable for, and they have to give a lot of data to the ministry, really hundreds of data. And they were quite proud that the hundreds of data were reduced by, let's say, from 600 to 500. And that was their big thing. But then I looked through all those data, and all those data were so very old-fashioned, you could say, a new public management-like data, like production and money and how many people in the labor force were ill this year and this kind of thing. But there were no, you could say, data that were asking about what is the movement that you should make in future. So what we do now to promote this is in our own facilities, so to the non-executive board members, that we should have a board vision. And the board vision should be programmed to the challenges that you have to have in your own adherent situations, or in your region or in your town, etc. What is the challenge that you have, and how are you could say, pointing your way of being a board member to those challenges? And I think that can maybe in the next future make a move in the right direction.
Thank you so much, Nabil, for your questions. I want to give the floor to Matthijs, and there's another question from Marcel and a question from Isabel. We still have about 5-6 minutes left, so 2 minutes each. Mariah, if you're there. you said the 7th principle, positive health, is very much connected to the environment, SDGs, Green Deal. We should have to motivate citizens to accept with a paradigm of health. Is it something you have a question about, or is it a comment you made? You're still muted, Mariah. It isn't working.
Working?
Yes,
Yeah.
now it is.
Okay. Okay. Thank you. Yes, that is the question.
I think if Mariah is the only one that freezes up, that's her connection.
Yeah.
So Mariah, I'll mute you for a second. I ask it later.
Your line is a little bit unstable. Maybe we'll comment later on your question.
Marcel, can I ask you to introduce your question? Mariah, we get back at you in a few minutes. Marcel.
Yeah, of course. Well, as you already mentioned, Marius and Matthijs too, we were talking about Charmer, and to be honest, I was surprised that you mentioned him because, well, it's a nice theory, the theory EU. But as I look from the Charmer position, and we were talking about peace sensing, it seems that the seven principles, they compete with each other, and I'm going to explain you why I asked this question. I work at management in healthcare and the social domain in Eindhoven, and we work with students who work in healthcare, and we like to work at those 7 principles. But there's a great difficulty in how to choose, how to give priority. So can you give me advice or give us advice in, well, to choose?
Okay, I'm not so sure if you should choose, but that a context could say, okay, we are more ahead in this part, so we should work further on that one. And so what I, for example, said, we are not good in the Netherlands in integrating reporting and then make that as a person that could be an attempt in my organization to put that higher on the list. But maybe for a school, it could be quite interesting. I'm sometimes amazed that we know now from a lot of data that about 25% of the people who are universities on, or you could say schools of higher education, are also informal caregivers. Now, how can, for example, a school be an example to make this more balanced with their own school programs? So how can, for example, people who are informal caregiver and reflect on that, get education points, for example, and not be burdened by the educational system and being an informal caregiver? So I think one guiding for you could be, okay, what is in our region of our situation already working, and you don't have to put so much emphasis on it. And the other thing is, what can be your own responsibility to make things happen, what otherwise will not happen at all?
Now, the reason that I asked this question is because we like to co-create. But then it's a lack of, I think we don't talk enough with each other in the Dutch healthcare about when and how do we work on the same issues or the same principles. So the bottom line is, how do we co-create and doing the right things on the right moments?
Yeah, I agree. But maybe one thing also is that we are sometimes a little bit impatient. So what I always say, when you have a real innovation or transformational innovation, it's a slow, deep movement. So a beautiful example in the Netherlands was this decentralization operation in terms of social care and welfare. And then only a few months ago, we had this 5 years existence of this transformation. And then people were complaining, maybe also a little bit in Eindhoven, because a couple of things went wrong there, about, we are not doing well, we should change it again. No, you could say the challenge that was put in this decentralization will cost 20 years. So it's not 5 years, it's not able to do this in 5 years. Yeah, maybe you can do part of it in 5 years, but the really in-depth transformation, what is behind it, that will cost 20 years, and then you're doing quite well. So
Yeah.
give each other also a little bit time.
Yeah, thank you.
Deeper sentence. Okay, is it an answer to your question, Marcel?
Partially, but I'd like to, maybe you could find some time somewhere else.
Very
Yeah,
good,
perfect,
very
perfect.
good. Yeah, yeah.
So I want to go to Isabel and then come back to Mariah and go to the next part of our presentation. We have a few minutes. So Isabel?
Yeah, thank you very much, first of all, for this presentation, which is very interesting. And I especially like the slide about balanced ecosystems, especially because I'm doing a lot of research on integrated care and on informal care. So I was just wondering a little bit about your experience in getting this triad of clients, informal caregivers and formal caregivers together to take responsibility for their care, because what I see is that it is extremely difficult because it asks from formal caregivers to really change their attitude and to see clients and informal caregivers as a partner in care instead of their patient. And for informal caregivers, it's also very difficult because they do need to be empowered to be part of the care. Sometimes there are some problems with health literacy. And what I see is, I like the co-creation of Marcel, but here it's more on a care level. I see that co-creation or shared decision-making can help in that, but I was wondering if you had any experience on how you can align these three stakeholders to get better care.
I will give one example and then Matthijs will give an example. One, I think, quite nice example was in one hospital in Alkmaar, for example, but there's more hospitals who do it. And they say, okay, as a patient, try to declare who is your patient partner. That can be your spouse, that can be maybe one of your children when you're older, etc. And then all the communication will go together with this, you could say, patient partner. And the patient partner is also constantly questioned about, does this really fit your the patient in a way? So you make a combination, so you empower in a way the small system of the patient. But it starts and ends with that the professional is asking in a way from feedback. And feedback not in a way is, do I good or well? No, does this fit with your situation? Does this fit with the ability? Does this fit, etc.? So it's another way of being reflective. It's not about being satisfied or whatsoever. No, it's to help that patients, the expert patient, what I call, and that is not a very well trained or educated patient. The patient is expert in his own small, you could say, system, and that's one example. Maybe
yeah, I've got a small other example. Those are SMAs. Maybe some of you know it. They're shared medical appointments. It's an intervention, and I can explain a little bit. The interesting part is you have to be consequent within the different domains. So in the domain of volunteers or citizens or patients or professionals, you have to have that effect of co-creation and shared decision making, and you have to be consequent in doing that in all those domains. And this SMA is one of the examples to do that, and it's a shared medical appointment. 10 patients with similar complaints go to the doctor together and then be part of that learning group. And there's also different kinds of settings. I'm training quite a few practices now on a GP level, but trained about 50 teams in the past in hospitals. And that's a great example to come to co-creation, to go to peer-to-peer, to do some modeling, all based, I think, on the theories of Bandura from around the 60s, but bringing them into practice, because nowadays we still see one-on-one consultation is still the norm, whilst that whole group thinking, so we talk about community building, community strength, but within healthcare, we go one-on-one. So, so how to build communities within healthcare is one example of how to breach that reluctance almost to work together. Thank you for
absolutely, and extremely interesting. Never heard of these SMEs. So thank you so much.
Please, if you link in LinkedIn, you can ask some questions and I can share the information. So, Mariah, I want to try again if you your internet connection was a little bit slow, but and then we go to the next part.
It's better now.
Perfect.
Okay, thank you. I just want to comment that environmental issues is also very much connected with individual health. So we can use Green Deal principles and SDGs principles and environmental health more in personal health attitude.
Yeah.
So
I
that is
very agree upon that. For example, in this, and that's maybe a nice bridge also to the next part. For example, in this whole COVID period in the Netherlands, we saw, for example, a lot of people dying, elderly people dying, in that area in the Netherlands where there's a lot of what we call the fine dust. So there's the industry from the Belgian region, the German region, and the industrial parts of the Netherlands, and all this comes together in, you could say, a triangle between the cities of Eindhoven, Den Bosch, Tilburg, etc. And that part of the Netherlands is really the most polluted part. And that gives, you could say, permanently burden to the lungs. And when you then have also COVID, then you see also a high mortality. So this is very important to think of also about environmental issues more and more. And I think we should be much more involved in that. Yeah, thank you.
Thank you.
Okay, thank you so much again. So we go to the next part. That means that I have to share my screen again, which I'm already doing. So I go to the PowerPoint, and I guess we are. You actually heard that I'm surprised that it worked. So it worked just the first time. Learning in times of COVID. Marius will take it from here.
Yeah, first I want to introduce this scheme where you see that there is a timeline first. What is the past and what is the future? And I always use this scheme in terms of, say, let's look 20 years, for example, what has gone on. So start at 2000 and what will be ahead in 2040, for example. This is just a simple timeline. And then I use this whole idea of things that are more explicit or more implicit, that could also be discovered or undiscovered, or it could be in evidence-based guidelines, or things that we just didn't do we have not so much research about, etc. So this vertical axe, you can put a lot of different words. When you fill the scheme in, also in this period of COVID, then you see we have the management of the present system, and then we want to keep that present system living, and that's what we call a strategy or adaptive strategy. And what we see in these times of COVID, that when you look, for example, to Dutch media or the discussions in Parliament or the workforce of the you could say the special teams around the Ministry of Health, etc., they are constantly thinking about how to manage the present system and make it adaptive in terms of the COVID. I'll give a couple of examples. For example, in the first wave, we saw that there was this big burden on intensive care beds, and then we stopped the rest of the hospital, and a lot of people were on waiting lists, etc., because we could not manage. And then we make an adaptation, and we ordered at Philips company, they are by hazard in the Netherlands, 1,000 apparatus for inspiration. How do you call those things? The equipment, the things that you need for artificial inspiration. And the whole idea is that we now have 1,000 apparatus, but we don't use them because we didn't think about how to use this kind of things in a, you could say, coherent way, because it's not about the apparatus, no, it's about the staff, it's about the places where we can deal with those patients. So we try to adapt in that system, but we're not thinking, you could say, more deeply about what is the problem within the system or where those problems come from. Another beautiful example is the testing labs in the Netherlands. We had the idea that we had not capacity of the testing labs, but I think the real reason was that we have this open market in the Netherlands, and there was a big competition between commercial labs and, you could say, the more traditional labs, and if we didn't use just the capacity of the commercial labs. So we are just trying to fix things in the present system and are not thinking a little bit more deeper. And then I think what should come in place is what we would say the hidden values of the past. So values, that is what is in depth behind people. Why are they working in healthcare? And a beautiful example of those values are that at a certain moment we had a lack of staff in hospitals. Now, in another, we have the special situation that it's not that not enough people want to work in healthcare. No, every year, it's amazing, 80,000 new people come work in healthcare. But the work circumstances, the whole thing about what I mentioned before, the accountability, a lot of paperwork, all this kind of things, is that people after a while don't want to work in healthcare. So we have a lot of people every year that not work in healthcare anymore. They're well educated, they're well trained, but they don't want to work there anymore. They start to work like in airplanes or in restaurants or etc. because they really don't like to be in healthcare. Now, what was so interesting in the first wave, that we had a lack of staff. And then many people as volunteers who were working in healthcare said, we want to help you. We don't care about diplomas. It doesn't matter about what we have to do. We just want to help. And I think that deeper value that emerged in a way in our system. And that's, I think, what could be interesting, just not to do questions and answers, but I would like to do a small exercise. So I'll give you, let's say, 5 minutes as a group, and then it would be nice in the chat, but also to give some comments. What do you see in your own healthcare systems that is coming from the values that are in depth in healthcare by people who are motivated to work in healthcare, or some new technologies that we now see what never happened? And the obvious thing is that, for example, the teleconsulting, that we never used that of telemonitoring. And then immediately when we had this COVID period, there was a lot of possibility to introduce that and to really make a big jump. So what I would like to say is, okay, and that we, in this very difficult period, we also see emerge new ways of healthcare that could, I go back to Charmer, that could be pre-sensing possibilities for future healthcare. So give it 5 minutes or think a little bit about it, and then we come back to you and give some of you maybe the floor to give some of the nice examples what you saw in your own countries about emergence of complete new ways in the present COVID period.
So, of course, this is less than 5 minutes, but we do want to keep a little bit of the energy floating. So as input on Marius' question, I would really like to give you the floor again. I will stop sharing this presentation now so that we can all enjoy each other in gallery view, or at least the 4 that are on screen. I would invite you all to be on screen if it's possible, and share your experiences of those hidden values and sometimes hidden pearls that came to you or came above the surface in times of COVID. So please share your examples.
Yeah, Mike.
Yes, Maaike. If you unmute yourself, you're...
Well, it's more a value, and I was thinking when I was listening to Marius with his question, a conversation I had with my parents, because what is bringing also to us is the perception of, do we have to do everything we can? And the talking with my parents was about, if you get COVID-19, do you want to go to the intensive care unit? Do you want to be ventilated? What do you want and what do you don't want? And what I see in the Netherlands is that a lot of people are aware of that question and are making choices. And there is a difference, of course. That's, but what's different now is that we are more aware and are taking. We are talking about it, and we don't want to do anything always what's possible.
Yeah.
It's
a very good example. And what was in my role in Dutch healthcare very worrying, that was in the first wave that we didn't discuss this with so that from a national point of view, for example, all the nursing homes were closed, and we didn't ask the people who lived in those nursing homes or the family members. And now you see in the second wave that we really learned from that, and we now start to have these discussions. What I can share with the group, I will send it to Frederica, is a very interesting report from the Medical Ethical Committee of Sweden, a very comprehensive report about all this kind of ethical dimensions, much broader than only healthcare. So I will also share that with the group later on.
Thank you so much, Maaike, for your example. So are there other people that have an example, personal or within healthcare?
What I do see is that finally healthcare is starting to realize the value of e-health, digitalization, teleconsultations, and actually we're quite happy with that, and also patients were quite happy with that. So it's kind of the consultation room for the future, I believe.
Mm-hmm.
That's one thing. And the second thing that I saw is, especially because many COVID patients, of course, could not receive any family or loved ones, that the health professionals really took on the role of supporting the whole system of the patient in terms of being there for them and making contact with the family and involving family in the care.
Yeah.
So those are two things that I think I saw and we should keep.
Yep. But quite interesting also what, to elaborate a little bit on your examples, is that, for example, in the care of mentally handicapped people, but also sometimes in nursing homes, there was 2 observations when the family could not be there. Some people really get very lonely and really even there was, you would say, examples of suicide, for example, because they say, what is now, there's no reason to live anymore, this kind of things. That was the one extreme. But at the other extreme, there were also people, it's much more nice now, my family doesn't come anymore because it's more quiet and etc. So there's also this observation that for some people to be with some of your family members is very supportive, but sometimes it's also a burden for some of people and there is a lot of tension in when your family is constantly visiting you. So that was quite an interesting observation. So I think a second one was, and I'm very proud on that kind of locations. If it's not possible for every location, but now they have, for example, in some nursing homes, wards for COVID patients. So they are not going to hospitals, but they are then especially being isolated on a ward together with nurses, etc., so that they are still enjoying life and are not isolated constantly in loneliness. So all this kind of very interesting new things in the second wave we see now in the Netherlands.
Thank you. Are there any other examples? And if there are no examples, questions?
If I may just quickly share an observation, Matthijs. In the UK, what we've seen is, of course, COVID has done many things and many of them are negative, but there's quite a lot of positive aspects to it as well that we, in terms of emerging system, that needs to be considered for the future delivery design of what we are going to embark on. Because this is not for today. COVID is going to stay with us, I think, for some time. One of the key things we are seeing and observing is previously where there have been a lot of barriers to progressing work in an integrated way, be it from regulatory perspective, local politics perspective, or not willing to work together perspective, all of that have been put to aside and people are focusing around one thing, and one thing was, what is the outcome we want to achieve for the people? So all those information governance and information sharing issues, so to speak, which has taken 3 years to get to the stage of just talking to the regulators, were resolved overnight to delivery of the services through the web channels, for example. You know, and I think that there's quite a lot in it to learn from, and we should not forget where we have come to in that time.
Yeah, yeah. Thank you.
Thank you.
Thank you for sharing. Yeah.
Great. Are there any other comments, questions, or things you want to elaborate on?
Yeah, and otherwise we will go.
And otherwise, this session is running to its end, to
Yeah.
its final.
But maybe to give you some last information, and then I give the floor back to Matthijs again. What we'll do, we'll share the presentation with you. We'll share also this report of the Swedish Medical Ethical Committee, what is quite interesting, I think, to read in times of COVID. And that's for the Dutch people. We will do also in our scientific board, so that is the Wetenschappelijk Adviesraad from our society, research on what do we learn from COVID, and how can we in a way look also when you look to the board members, what should be lessons learned, and how to deal with that in future. So
okay, this is it. So we will leave this session. Thank you so much for being here and be an interactive partner with us, and thank you so much.